Well, welcome everybody. Today I want to welcome you to today's Indiana Rural Health Association Lunch and Learn webinar. Our presenter today is Jim Miller with Indiana Rural Health Association. Jim has over 35 years of experience in healthcare financial management, having served as a consultant and manager for government payers, a large hospital provider, and in for-profit agency and provider association capacities. Jim specializes in revenue cycle management, reimbursement, corporate compliance, and leadership development. He has held leadership posts at the state and national levels for healthcare financial management, the HFMA, is a former board member for the Indiana Rural Health Association, is the current state chairperson of the Indiana State Uniform Billing Committee, and serves on provider advisory councils for the Medicare and Indiana Medicaid programs. He's a graduate of Wabash College in Crawfordsville, Indiana, and he is also the revenue cycle consultant for the Indiana Rural Health Association. So today, Jim is going to talk to us about care coordination and billing. Care coordination is an integrated, comprehensive delivery care plan specifically tailored for a patient's healthcare and well-being needs. Healthcare providers and commercial and government insurers alike recognize the value of care coordination, although barriers to its optimal use and reimbursement remain. This Lunch and Learn will explore the many facets and benefits of care coordination and its impact on the healthcare delivery system. So now I'm going to pass it on to our one and only Jim Miller. Thanks, Jim.
Okay, thanks, Kate. I don't know if one and only is the appropriate, but hey, we'll go for it. Thanks. Here's the title slide. As Katie mentioned about the chronic care management, we're going to talk a little bit about chronologically ill folks today and about a variety of issues related to the CCM program administered through Medicare. I do want to mention that this is, fairly an overview of the program. There's a lot of nuances and detail to the program that probably can't be addressed in an hour. And certainly, if you've got questions that need to be followed up, I'll be happy to do so. But I'm going to try to hit a lot of different topics here today about the CCM program. If you'll take down my email address, if you have any questions, it's pretty simple. It's jmiller, M-I-L-L-E-R, jmiller at Indiana RHA, as in Rural Health Association.org. That's jmiller at Indiana RHA.org. And I'll have the email address at the end of my presentation as well. I wanted to get that off to you in case you want copies of these slides or you want some further questions or delve into some issues that maybe we're not able to address because of time constraints today. So let's get into it. This first slide talks a little bit about a discrepancy, a little bit between our folks at CMS and CDC about the volume or the number of chronically challenged people in the United States. CMS says there's about 117 million adults that have one or more chronic health conditions, and 1 in 4 have 2 or more. 1 or more would be about 35.5% of the population based on a US census of about 330 million men, women, and children. 1 in 4 would be about 82.5 million out of about 330 million Americans or people that reside in the US. The CDC numbers are a little higher. CDC out of Atlanta claims that there's about 6 in 10 that Americans have some type of chronic illness. We'll talk about what those are in just a second. And 4 in 10 have 2 or more. Regardless of who you believe or which agency is correct, there will, that's obviously a serious health problem in our country. Then there's a lot of folks that suffer from some type of chronic disease. And as your faithful host today, I actually fall into the category of having 2 or more chronic health conditions. I am a cancer patient and I'm hypertensive as well. And as you'll see in a few minutes, cancer and hypertension are 2 of the many conditions that are considered chronic according to both the CMS and CDC. This session, I've got a lot of bullets here on what we're going to talk about in this overview, and you can see what what they are. And we'll touch on some more than others and go into greater detail. We'll also conclude with a little case example using substance abuse as a example of how we can utilize the chronic care management program for patients that are subject to substance abuse or opiate abuse. And that'll be at the conclusion of this presentation. But the first part of this presentation will focus primarily on some of the mechanics of the CCM program. Okay, this is according to a publication from the CMS, the Centers for Medicare and Medicaid Services. And down at the bottom, you see a reference, the Medicare Learning News, the MLN series, and you see the number 909188, published in July of 2019. That's the citation for many of the items that we're going to talk about today. But defining the extent of a CCM service, you can see the definition that actually goes on to 2 pages or 2 screens that I'll talk about. And you, instead of reading to you, I'll just let you take a second to read about what is considered a CCM service. And we'll go to the next slide. There is a portion of this slide that I think is very important or principal to the efforts of the CCM program. And it discusses on line 3, advanced primary care such as a continuous relationship with a designated member of a care team and patient support for chronic diseases to achieve health goals. I think that is really the crux of the CCM program, working with a designated care team member to achieve the goals that have been established and try to resolve these chronic care issues that are facing the patient. The care access and continuity is a crucial component of the CCM program. And there's 3 bullets that are listed here. One at the bottom talks about how to communicate with the patient, or communication between the patient and the practitioner, the availability of 24 hours, 7 days a week access to a qualified health professional and clinical staff. I think the second bullet is really the real intent of the program, to ensure the continuity of care with a designated care team member for scheduling routine ongoing appointments is really the crux of the program, to really delve into the chronic care issues and try to get a favorable and favorable health outcome for the patients as they proceed through this program. Comprehensive care management itself is basically defined as these 5 bullets. They are all in coordination with the chronic care team member who's in charge of the patient's care. And I think the first one is really sets the tone for the others. It's a systematic approach to assess the patient's medical, psychological, and functional needs. What are those needs from those 3 perspectives? And then the other 4 bullets really kind of fall in line with what those particular psychological, medical, and functional needs are. Certainly, patient medication management and self-medication are a key component of it, but it's all part of that first bullet, which is a systematic assessment of what really those patient needs are. And we'll talk a little bit about medication management and some of the resources that are available as part of the CCM program later in the program. Another component of the CCM program is actually a transitional care management aspect. And that has to do with primarily transitioning patients from one level of care to another. This typically occurs after maybe an emergency room visit or some type of a discharge from a hospital or some type of care facility where there's a transition from a more acute setting to a subacute or to a home setting. That entails a lot of documentation exchange between providers and information in terms of health information management and whatever those assessments are for CCM purposes to really help that patient transition from a higher level to a lower level of care to maintain a continuity of care. The TCM program is kind of a component of the CCM program and something we'll just touch on here. Obviously, TCM and the ability to transfer a patient from a higher level to a lower level of care deserves a pretty intense description in its own right, which we really probably could use as a source of another lunch and learn and discuss it from a more global perspective. But I did want to touch on the fact that there are a couple of CPT codes that have been identified in the AMA code book, the CPT code book, that identifies those appropriate TCM procedures. CPT 99495 and 99496 deal with the discharge planning, the transitional care involving the discharge from a higher level and transition from a higher level to a lower level of care. And the Indiana non-facility price, in other words, a physician price for that service, is identified on this particular slide. And for your information, as we'll go into the presentation a little later, we'll look at some of the CCM codes. If you're looking for specific or verification or specific coding and the pricing that is available for Medicare for 2019, that is available on the Medicare physician fee schedule. And the numbers that I'm going to provide, or the pricing that I'm going to provide, is related to the Indiana MAC, the Medicare Administrative Contractor for Indiana. What their pricing is listed on their particular page. So if you go out and you access the physician fee schedule for Medicare, you want to make sure that you're indicating the Indiana fee schedule. If you're an Indiana provider calling in today, you want to make sure that you look at the Indiana fee schedule, although there's a national fee schedule out there as well that'll give you a listing of all the various MACs, but we're focusing specifically on the Indiana fee schedule today. Okay, let's talk a little bit about patient eligibility for this program. And here again, I'm not going to read to you, but it basically is the patient eligible for CCM requires 2 or more chronic conditions, such as mine as cancer and hypertension, and you're expected to have those particular conditions for at least 12 months or until the death of the patient. These conditions basically put the patient at a significant risk, a higher risk of a death or some type of functional decline. These are the folks that are eligible under Medicare for these CCM services. The chronic conditions, the main ones that are listed here, but they're not limited to, but I did want to put the main ones that are out there that are generally considered the principal chronic conditions that are eligible for CCM management. And you can see the list there is fairly comprehensive. You've got a total of 12 that are listed there. And there's no surprises, particularly on that list that are on there. I think the one thing that you should be aware of, that obesity is not considered on that list, but certainly it's a major health risk, particularly in Indiana, where obesity is a major risk factor in this state. Other states, not as much, but in Indiana, certainly it is. And you can see the classics that are out there in terms of Alzheimer's, cardiovascular disease, depression, which we'll talk a little bit about some of the substance abuse and opiate abuse, which might contribute to the depression issues, hypertension out there, COPD, cancer, diabetes. All these are considered major factors in the chronic conditions eligible for CCM management. For a patient to be eligible under the CCM program, it would require first a a face-to-face encounter with a practitioner before they're basically enrolled or initiated into the program. At that point, the practitioner and the patient agree to participate in the CCM program, which takes intervention on both parts. The patient would then would essentially agree to a consent to receive these CCM services. And that consent basically says that they are going to be willing to engage in these services, that they understand there is a cost-sharing component, which we'll talk a little bit more later on, that there really is one primary practitioner that they should deal with to deal with their chronic care management needs. And the patient at any time, regardless of cause, can end that CCM services. And as you'll see a little later, probably one of the biggest reasons for this CCM program to end is the cost-sharing component. But there is some potentially good news on that front as well. We'll talk about that a little later. All right, who's eligible to participate as a practitioner in the program? You can see the 5 that are listed up there. Physicians generally are the main practitioners that are involved in the CCM program, although it is not limited to physicians. You can see the other 4 that are listed there as well. I think it's important to note that limited licensed practitioners, and I've given 3 examples, clinical psychologists, podiatrists, and dentists, are not eligible to participate in this program as a CCM practitioner. However, they may be called upon or consulted with by the CCM practitioner in cases to help coordinate managed care. Upon enrollment, the patient is, there is a development of a comprehensive care plan for all these health issues that are listed here as part of the CCM program. And the care plan is designed to develop important outcomes and prognosis for the patient, which is really what we're trying to do. And that's done through a series of measurable treatment goals, evidence-based information that the practitioner and the patient can work on to try to reach some type of sufficient measurable goals that are realistic given the patient's conditions. The other things that I think that are important on this, we talked a little bit about medical management and medication management, and the community and social services, the resources that are available to help the patient and the practitioner, ordered and arranged through the practitioner to help the patient achieve those outcome goals. The plan itself is described as a person-centered electronic care plan based on a physical, mental, cognitive, psychosocial, functional, and environmental assessment. All those factors will go into the development of that care plan to reach the desired health plans. I think the important one here is that are listed here. Obviously, the patient is engaged, and they're also provided with the final care plan in conjunction with their work with the practitioner. But I think one of the key components of the planning and the development of the plan are the various resources that are available from various community organizations that can assist the patient in reaching those established goals. Now, we want to look at some various levels of care that the CCM program encompasses. And they're based on primarily 20-minute or on time components to determine the level of care. And here again, these codes that are billable by the practitioner are available in the 2018 AMA CPT code book for a description of what these various codes are. And these are the principal codes. We'll look at 4. They're the principal codes that are part of the CCM program. The first one is 99490, and I've given you a description on what is essentially required by CPT coding to meet the qualifications for a 99490 code. The key component is really the time elements that are involved here, and it requires at least 20 minutes of clinical staff time in a month in working with the patient, and it assumes that that patient will receive 15 minutes of work by the actual billing practitioner per month in help coordinating this care. And that could result in after the initial visit, could be face-to-face, or it could be by phone, or some of the means, electronic means that we'll looking at in terms of internet, phone calls, the various electronic means that can be reached, the patient can agree to be reached through by the practitioner to assist in the development of their care. I think the key component on this is the time, to make sure that that time is met and is charted and in the medical record, to ensure if there would be an audit that those particular minutes would be established for for a period of a month for 30 days that are listed in a month. Now for 99-490, as you'll see, as well as for the other three codes, there are the three components that we talked about earlier as part of the program, and meeting the criteria for the 99-490 and the other codes, is that the two chronic conditions are expected to last for 12 months. The patient is certainly in a position, if they don't receive a proper coordination of care and necessary care, that they're at a significant risk of death or a functional decline, and that the comprehensive care plan is either established, it's implemented, revised, or monitored based on the physician and their coordination with the patients. In Indiana, if the patient bills Medicare, if the provider bills Medicare for their time, the 20 minutes of at least 20 minutes of clinical staff time, in Indiana Medicare, under the Medicare fee schedule, they will be paid $39.75 for that month's worth of care through the CCM program. For 99-491, the time element is a little greater. It's at least 30 minutes of time per calendar month. But in this case, this is the one exception. The clinical staff time does not count toward 30-minute threshold. And that's the only one of the four codes that we'll look at where that does not count toward the 30-minute threshold. Essentially what they're saying is this is a little bit more intense care coordination for the patient, generally done through the provider or through the clinical staff time. They need a little bit more outside work in working with resources, possibly community associations, other groups, to help coordinate the care along with the primary care physician or one of the other four practitioners that were listed as eligible. The same three requirements in terms of chronic conditions, the significant risk of death, functional decline, and how the comprehensive plan might be revised or looked at is also part of this 30 minutes at least per calendar month. As you'll notice that the time element is increased under 99-491, as is the non-facility price up to $79.65 under the Medicare fee schedule for Indiana. 99-487 is the first code that we'll look at under complex CCCM. And this is where there is the same three basic criteria that we've seen below in terms of the chronic conditions, the risk of death, the comprehensive care plan is looked at. But there's also a component of a major medical decision-making made by the CCM practitioner and the staff. And that entails a more comprehensive and a more complex review of care for the patient. And it looks at this comprehensive review of at least 60 minutes of time per calendar month. And the time, that 60 minutes does include face-to-face encounters with the clinical staff time if the patient sees things face-to-face. The face-to-face time as well as non-face-to-face time or coordination of care will combine to meet the 60-minute component per month. The higher complexity in the medical decision making does result in a higher non-facility price under Indiana Medicare's fee schedule of $87.20. This is current payments of $87.20, and as we'll see in the next slide, in $99,489, there is reportedly in 2020, and I don't know the numbers yet because the fee schedule hasn't been posted, but in fee schedule 2020, the report is that the fee schedules will go higher both for CCM and for transitional care management. That's what I've heard through the grapevine. Okay, at $99,489, this is where the additional time goes beyond the 60 minutes, and maybe the patient has some complex CCM needs that go beyond just the 60 minutes, and the provider is billing for not only the $99,487, but also for $99,489 because of a need to add additional time to assist in development of the plan, or maybe a substantial revision of the plan based on the patient's needs and their chronic conditions. Notice the three, under the bullets, the three contingencies are still there in terms of 2 or more conditions, the significant risk of death, functional decline, and the establishment, or in this case, most likely a substantial revision of the care plan based on the patient's need. So if the review by the practitioner, the CCM practitioner, exceeds the 60-minute parameter under $99,487, and there's an additional 30 minutes of time that is required to meet the patient's needs to reach that desired health outcome, the additional 30 minutes under $99,489 can be billed as well. And for each 30-minute component, the Medicare fee schedule for Indiana would be an additional $43.60 currently. Okay, just a few items that probably are important to note as a result of the CCM levels of care. These services that may not be directly provided by the billing practitioner, but are done by this clinical staff under the direction of the billing practitioner, are considered incident to. And that's a fairly common provision under Medicare. If the physician directs care to be done by someone else, that is considered incident to. As well as Medicare is also getting away from the direct supervision requirement, which is generally has been used as part of outpatient therapeutic services such as OT, occupational therapy, physical therapy, respiratory therapy. They're getting away from a lot of that and doing what is described as general supervision, which basically says that the services may not be directly provided by the billing provider or the billing practitioner, but is under their general supervision to make sure that the care is done, even though their general presence is not required. And we're seeing that not just with CCM, but we're seeing that in other outpatient therapeutic services. And this is particularly important in the rural setting, where physician services, where the physician may not be actually present on site, where the occupational or physical therapy or other therapy services are performed, just because the physician cannot be in 2 places at one time. We wanted to talk just briefly about CCM is available as well through rural health clinics and through federally qualified health centers. And I just put this statement in here to alert those types of providers that CCM services are available through those types of settings, FQHCs and RHCs. However, they use a different billing mechanism and a whole different billing structure and actual different codes to provide CCM assistance in that particular setting. It would probably necessitate a different lunch and learn or a different setting to discuss specifically rural health clinics and FQHC's participation in the CCM program, which we possibly could do down the road as another lunch and learn. But I at least wanted to alert you to the fact that FQHCs and RHCs are eligible to perform these services in their particular settings. They are one of the resources that are available through the CCM program to provide these services. And we'll talk about some of the resources now. There's a whole litany of information that's out there regarding the CCM program. And I just provided just a sampling of those that are out there in terms of the physicians' involvement through the CCM program. You can find that out through CMS.gov. And if you forward slash through the physician fee schedule, you'll find information about the CCM program, additional information that we may or may not be able to address in this short period of time. I talked about FQHCs and RHCs. There's information that's available through CMS.gov. And if you look under the FQHC Center, that will address both FQHCs and RHCs, the types of services that are available and the types of resources that are available to those provider types for the CCM program. Similarly, for hospital outpatient departments that are performing the services. Now, the fee schedule I talked about earlier for those particular codes were for non-facilities. Those facility-based programs would be, information is available on the outpatient PPS website, which is a whole different animal than the physician fee schedule. OPPS is a different setting for both prospective payment system facilities and for any type of critical access hospitals that are participating in this program. And then also there's information about the chronic conditions available through CMS.gov and the research that for those particular chronic conditions is available through that /. The governing regulations for the CCM program were originally finalized in the 2014 Medicare PFS final rule. That's the physician fee schedule final rule. It was updated in 2015 and was also updated in 2017. The program has been around since 2015 as part of the original 2014 final rule, which took effect in 2015. All right, now let's talk a little bit about some of the barriers to the CCM program. In my mind, it's a very comprehensive and a very constructive program to help patients with these chronic conditions. However, there is some barriers to this program, some hurdles that the CCM program needs to overcome for it to be totally functional and successful. As I mentioned earlier, it did start in 2015 as a result of the 2014 PFS final rule. But I think the three main barriers, and they are somewhat interrelated, are the three that are listed on slide 21. The first and foremost is perhaps patient reluctance and resistance to get into a program that they don't understand, that they don't understand the requirements of what their participation, of what their engagement will be, and working with the various resources that are provided to them, and with the physician or the practitioner who is deemed as their CCM practitioner. I think patients are somewhat reluctant to get into programs, whether they're 65 or older or under, if they're disabled in some regards. I think it just takes, as the second bullet indicates, more program awareness about the benefits of the CCM program. And I think that's contingent on CMS. I think it's contingent on the Medicare program. I think it's contingent on practitioners that are participating in CCM. I think it's contingent on all of us to participate in providing more awareness about this particular program. It's a relatively new program, just in its fourth year, but those hurdles and those barriers remain. I think one of the barriers that possibly is reduced as part of this patient resistance is the cost sharing component. And I addressed this a little earlier when I talked about the patients have the ability to drop out of CCM at any time. And I think this might be one of the big issues. There are co-payments that are involved with these CCM program. They're fairly minimal, $5 copay. It doesn't sound like a lot of problems or wouldn't be a lot of money, but these affect a lot of beneficiaries who are on fixed incomes, and just the facing the $5 co-payments on a monthly basis, receiving a statement from the provider that they owe this $5 co-payment is a burden to folks that are on fixed income. And sometimes they face tough decisions on whether they're going to pay their utility bills, whether they're going to feed their pets, whether they're going to be able to meet their medication requirements. Does that result in pill splitting rather than taking the recommended dosage prescribed by their physician? All these factors weigh in on beneficiaries who are on fixed incomes. And if they're facing a copayment each month, that could be a barrier to them to continue to participate in this program. And during 2017 and in late 2016 and in 2017, I was in an interim stint at an Indiana rural hospital that had implemented the CCM program. And this was a major barrier for the success of that rural hospital in getting patients and beneficiaries to continue in the program. We had a nurse who was designated to provide the CCM program for these patients. She was diligent in all aspects and tried to really run up and ramp up the program, but she faced this barrier of the co-payments, and we had a significant number of patients that opted out of the program because of that what would be considered by most folks a nominal co-payment amount. However, a nominal co-payment amount to you and me may be a substantial co-payment amount to someone on a fixed income. The good news is there is some action, I guess we could say this is good news. There is some action in Congress to try to eliminate this out-of-pocket expenses associated with care coordination and care coordination and chronic care management programs. And you see these House resolutions 3436 and 3346. One would eliminate it, period, and one would eliminate it beginning in 2021. There has been a little movement with House Resolution 3346. It's under current review in the House Ways and Means Committee. But as you well know, with all the ruckus and circus-like atmosphere in Washington right now, there's not a lot getting done legislatively because of all the concerns with the impeachment proceedings and attention to that issue. Congress has really stalled on a lot of action, not just with these particular resolutions, but others that are involving one that I've been studying closely is in terms of drug savings. A lot of action there as well is just not moving because of what's happening in Congress as we speak. But at least there is activities or action or measures to try to resolve this out-of-pocket barrier that is facing CCM patients. One thing I think folks need to understand as well, Medicare does not have a lot of co-payments that are waived under their regulations or their provisions of the program. Some of the ones that are waived are screening services, but mostly anything that is therapeutic in nature has some type of cost sharing or co-payment component to it that the beneficiaries have to face or pay to be to continue or to be or that they're responsible for as a result of their therapeutic program. Prospects for the future of this program. CMS seems supportive of this program in the sense that they contend that it saves the program, the overall Medicare program, about $74 per patient per month for all those that are enrolled, which is a fairly substantial amount of money. I don't know the actual number of people that are enrolled because obviously there are people that participate and those that drop off because of the co-payment issues. I think here again, I think it is all contingent on all of us to expand the program awareness to even bolster the numbers, which would result in even more savings for the Medicare program for use in other areas that are critical for the Medicare program itself. Now, where there's obviously good news in that regard in terms of savings at a fairly substantial amount at $74 a month, there obviously is some concerns that have been raised through the Office of Inspector General, which is a enforcement arm of the Department of Health and Human Services, which administers CMS. Since 2015 and 16, there were some payments that were made for the CCM program that the Office of Inspector General has identified that were overpaid in the amount of $640,000 plus based on almost or a little over 20,000 claims. And you can see the various numbers that the Office of Inspector General has seen in terms of either, well, I would say at this point, abusive practices. I would say they were fraudulent practices. I think it may be the result of lack of understanding or newness to the program that providers billed for some services that overlapped. They billed twice for something. But the bottom line is those overpayments of $640,000 would have resulted in $173,000 in co-payments that were deemed improper, assessed to beneficiaries here again, which would hurt the expansion of the program, growth in the program because of the co-payment contingency. Okay, in the time allotted left, I wanted to just talk a little bit about a case study or example of where the CCM program could have helped in dealing with a particular chronic condition. In this case, we're going to look at substance abuse and opiate abuse. And this particular information that follows was provided to me by Dr. Amna Anwar, who is a staff member of the Indiana Rural Health Association. She is also the project director for the Indiana Rural Opioid Consortium, also known as IRHA. This is a program in 14 Indiana counties that is designed to reduce morbidity and mortality rates associated with substance and opiate use disorder in those particular counties using preventative treatment and recovery services. And it fits, I think, a pretty good model related to how the CCM program can be used with this particular chronic issue. The first thing you need to know is the definition of what is considered substance abuse disorder. And it's defined as a chronic, there again, chronic, relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful consequences. This substance abuse disorder certainly has cycles of the active disease, remission, and in active disease again. There's those cycles that occur as a result of this disorder. And that about half of these cases, from 40 to 60%, are genetic in nature. Severe and chronic substance abuse disorder is called, or is described as addiction. So when it gets to the point where it's severe and it's chronic, it's described as addictive for our purposes. This is a model of the various components of drug abuse treatment, and you can see on this model the various boxes of the various ways that the practitioners, the care teams will use in their process to help identify disorders and how the drug abuse can be treated. You'll see intake, you'll see case management, behavior therapy, continuing care, pharmacology, and pharmacotherapy, support groups, all those treatment plan, of course, as we talked about earlier. All those components are important in developing a drug abuse treatment program. And then on the outside, in the gray box or the gray ovals, you'll see the resources that are available outside of the treatment. That's a CCM model for use of resources can be used to help assist a patient in crisis during a drug abuse treatment. And these are the resources that we talk about, available through the community, through churches, through a variety of various resources that are out there to help the patient during their crisis. In terms of how we could use pharmaceuticals to help the patient in these various types of disorders, whether it's alcohol use, opiate use, tobacco use. By the way, all three of these are classic in what is described as polyaddictive behaviors. These are some of the drugs that can be used to treat the various disorders that are listed there. These polyaddictive behaviors are classic situations that will occur when a patient gets addicted to some type of item, some type of substance that they'll get addicted to other things. And this can lead to other disorders, addictive behaviors such as gambling, sex disorders. All of these are part of a polyaddictive behavior that these patients also fall into this trap because of their disorders with one or three, or particularly with the opiate disorder use. In terms of treatments, how we do psychosocial and behavioral therapy, these will all be done in various levels of care, whether they're done on an outpatient basis, inpatient, intensive outpatient basis, partial hospitalization through residential. Those are all various levels of care to deal with behavioral therapy. And the modalities are listed there are essentially how the treatment is experienced or performed through cognitive behavior therapy, enhancement therapy, through motivation, and contingency management. All of these are components or ways that these psychosocial and behavioral therapies are performed. The third component, of course, is recovery support. And you can see the three bullets there that are part of the recovery support services that are out there. Here again, means that are able to provide support to the patient, for the patient as they continue to deal with these cycles of addiction, of relapses, as they go into remission and they go back into addictive behaviors. All of these recovery support are to help the patient deal with these situations if they go into, if they relapse to their addictive behavior, or while they're in remission from addictive behaviors, to provide them with some type of support during that recovery process. I think this is an important slide in the sense that it talks about how long should the treatment last in dealing with the well, with the CCM model or in this substance abuse treatment model that CCM could fit in a solid or where it fits in well with the CCM model. You can read in there that particular gray box that's provided through the World Health Organization. I think that the key lines in this particular definition of how long the treatment should last is in most cases, treatment will be required in the long term or even throughout life. In other words, this isn't something that's just a periodic situation. It is a long-term situation that is going to face this patient for the remainder of their life. The treatment should be aimed to reduce or stop the opiate use, but also to improve the health and social functioning and to help patients avoid some of the more serious consequences of drug use. So it's a lifelong effort, a long-term effort to do just that, to help the patients avoid some of the more serious consequences of drug use. Not just the addictive behavior itself, but also the toll that it takes on the patient in terms of their liver, their kidneys, the various internal organs that are damaged through ongoing opiate and substance abuse disorders. The final slide that goes with the substance abuse disorders is what is described as a typical encounter with the patient. And these are kind of consistent with that model that we looked at earlier. If the provider meets with the patient and there's a suspicion of a substance abuse disorder, then the screening would take place that would capture the various indications of that substance abuse. And then once that substance abuse disorder is screened and it captures that particular substance abuse disorder or identifies it, then we need to identify how that plan can be created for a lifetime or certainly for a long time, if not lifetime, to provide care for that patient to avoid relapse into that substance abuse disorder, to identify what recent use of substance abuse or opiate use has occurred to create the disorder, and then use the DSM-5, which is also kind of the equivalent of the ICD-10 diagnoses, to determine the diagnosis of the opiate use disorder, to really drill down to determine what is that diagnosis based on the screening materials and the suspicion of the practitioner of determining what that disorder is. I do have just a few items that I wanted to talk about before we conclude, or we can take a brief time for some questions. I did see a recent article in the Indianapolis Star that was dated December 1st on a Sunday, and it was authored by Jim Carroll, who is the nation's drug czar. In 2018, there were 70,000 Americans, which equates to about 200 a day, Americans that died of an overdose of some type of substance abuse or of a substance abuse disorder that died of an overdose. That's 200 a day nationwide. That was in 2018. 70,000 folks died of some type of overdose. And I looked, compared that with some other disorders, some other conditions, other illnesses, that to kind of put that 70,000 number in perspective. And 70,000, those 70,000 overdoses were more than Americans died in that year from flu or pneumonia, from kidney disease, and suicides. Now, the good news is, I guess, I don't know if I'd call it good news, but there appears to be some decline in the deaths of opiate use that seems to have plateaued out since 2018, and there seems to be a somewhat of a decline However, the numbers are still way too high and way too unacceptable. I have a friend who is a prosecutor in Montgomery County, Indiana, which is west of Indianapolis. And he confirmed to me probably about 6 months ago that in his particular county, he is seeing less arrest for opiate use or opiate-related use in his county than he did 3 or 4 years ago. However, the offset in opiate arrest have been an increase in meth use. So we're trading meth use for opiate use. All that stuff is just bad. And if there is such a good news, I don't consider that particularly good news that people are trading one for the other. But there appears to be, at least in the county that I'm referring to, a drop in opiate use offset by the increase in meth use. So take it as it is. There is some, I guess, some good news in that front in terms of opiates, if you want to consider that good news. I think some other good news that's out there is that the federal government and our state folks are working and recognizing the importance of this issue. 70,000 deaths is just way too many. And there are efforts to increase funding, and there are efforts to increase awareness, but it's still a long road ahead for all of us to work on this problem. And I think your participation in today's Lunch and Learn is a step in that direction. I encourage if you're participating in the program, I applaud your efforts in that regard. If you're not, I hope that you do start to participate in this program to help get some of this stuff eradicated and get it off the streets and help people who desperately need some help. With that, I want to thank you for participating in today's Lunch and Learn. And I want to wish all of you the happiest of holidays to you and your family and your friends. And let's work for a better 2020. I think the vision, so to speak, for 2020 is hopeful. Let's make sure that it comes to fruition. And with that, I thank you, and I'll conclude. Is there anyone out there who would like to address any questions that I may or may not have touched? Thank you.